So I was thinking of starting a series of some longer form content pieces talking about some of the things that we commonly hear in the endometriosis community. I'm thinking of calling it something like Endometriosis Yap or Yapping About Endometriosis. So we'll see if I can make a series out of it. But one of the first things that I think folks tend to encounter when they come into the endometriosis community, or something that we hear very frequently, is the fact that endometriosis is not endometrium. And when I have medical students in my operating room, or I'm teaching medical students and we're discussing the topic of endometriosis, I will first ask them, what is the definition of endometriosis? And a lot of them will say, well, it's endometrium outside of the uterus, or it's endometrial glands and stroma outside of the uterus. And, a lot of medical texts still do quote this definition, but I say, you're on the right track, but we have to understand that in this, maybe just a slight semantic difference to you, but it really underscores the pathophysiology of the disease and why a lot of the purported treatments don't work all the time in the way that we expect them to. And so then I correct them and say, well, it's endometrial-like tissue that's located outside of the uterus. And, you can put that into a corollary of the statement that we hear all the time of endometriosis is not endometrium. And this is important from a pathophysiology standpoint because, take, for example, one of the treatments that we hear recommended for endometriosis all the time in the form of hormone therapy, or I'll refer to it as birth control for ease of just saying that. When a person takes birth control and we look at their lining of their uterus, their endometrium, their true endometrium, we know reliably in the vast majority of patients how that endometrium is going to respond. Over time, birth control, even birth control that contains both an estrogen and a progesterone component, will tend to have an overall progesterone-like effect on many patients, meaning that it's going to thin out that lining to where the patient may not have any bleeding when they're doing their placebo week, or when they do an ultrasound, they may have a very, very thin endometrial lining. Okay. Now, that has been somewhat extrapolated to endometriosis care, and pardon my dog, but that has been somewhat extrapolated to endometriosis care. And we think, hey, because endometriosis is kind of like the endometrium, maybe we'll have that similar response. But the problem is we can't really guarantee that response in everybody. And it's not so easy for us to go and check who's having that type of response and who's not, because it would take a surgery. You'd have to put somebody under general anesthesia. So there's no good way to surveil or monitor that. And so that really underlies the fact why I tell many patients that I can't guarantee that birth control is going to suppress or thin out their endometriosis, and why we just can't we don't really have a leg to stand on to call that like a reliable treatment, because it's kind of a crapshoot, honestly. So I hope that explanation underscores some of the pathophysiology of endometriosis. I mean, obviously there's a lot we know, there's a lot we don't know, there's a lot we still need to fund research for. And so, like I said, I want to use this series to address some of these common phrases and things that we hear in the endometriosis community. Some of us have been in this community for years and decades, but others are new to it. And so they may, need some education about why we say that and why that is important to endometriosis care. So, like this, share this, let me know if you like this, if you want to see the series continue. And of course, let me know if you have any questions about anything I said. Thanks.